Okay, are you able to see my screen?
Yes.
Perfect. Okay, so great to hear so many of you were able to attend yesterday's event, and I assure you we're going to be presenting different results today. So if you didn't get to attend yesterday's event, that webinar or that panel will be made available online if it's not already. And of course, happy to speak more to those results if people are interested. So a little bit of background about the study. This is the only sort of area of overlap you're going to hear. But essentially, this study began in 2020, when, of course, we were seeing a growing body of evidence and also just concerns around increases in violence against women during the pandemic, of course, due to risk factors for violence against women, like being sheltered in place with abusers, economic stress, and the psychological distress that came along with the pandemic. And there was initial sort of snapshot, high-level national evidence being published around the challenges occurring in violence against women sectors across the country, which you can see in this infographic created by Inova. But as a team, we really wanted to develop a more in-depth understanding of what was happening locally within a particular sector. And of course, where we were working at the time was the Greater Toronto Area. And so our goal in the Marco VAW study was to build a shared understanding of challenges and strengths in Toronto's response to violence against women, or VAW, and to develop actionable recommendations. And we had 3 research questions. The first was, how have VAW organizations adapted to the pandemic? Second, how have contextual factors like funding influenced these adaptations? And third, how well were services meeting the needs of survivors? And so we're going to answer those 3 research questions with our data today. Just to give you a little bit more context to the study, so we used a community-based mixed methods design, which essentially means that we integrated both qualitative and quantitative data from our participants. And the project was co-led by myself as an academic researcher and a community-based researcher, Priya Shastri, who's also with us today. Our team include applied academic researchers who specialize in violence against women, VAW and allied organizational representatives, and women with lived experience of violence. And we had the pleasure of having an advisory group along with our project, which was made up of members of the Violence Against Women Coordinating Committee, or the VAWCC, of the Toronto region. So beginning in fall of 2020, we came together as a research team with our advisory group and with VAW organizational reps to develop a conceptual framework of how we thought programs work across the VAW sector, what are their short-term and long-term goals, and how might have these things been impacted by the pandemic. And we then used that framework to develop our data collection tools, including a survey of 127 VAW frontline and leadership staff across the GTA, which took place in the spring of 2021, a focus group with our advisory group members, and then interviews with a purposive sample of 18 VAW staff and 10 clients of VAW services across the GTA. And that took place up until September 2021. Throughout the study, we use what we call integrated knowledge translation, which means that essentially, as soon as we had our first set of results, we fed those back into the community, into the sector, to get feedback on how we were interpreting the results and how we should basically use those results to inform the next steps of data collection. So our research provides an in-depth snapshot of the experiences of certain VAW staff and survivors in the GTA during the study period, 2020 to 2021. And so while it's not necessarily representative of everybody's experiences across the entire sector, and it might not generalize to other places or other periods of time, our results do illustrate important challenges and successes in VAW systems work during the first 18 months of the pandemic that can inform areas for systematic improvement and best practices, both in this public health emergency and beyond. So to give you a little bit more of a sense of who participated in the study, we had 127 respondents, so 90 frontline and 37 leadership from over 30 Toronto VAW organizations. The average age of our staff participants was 41 years, ranging the majority ranging from 31 to 50 years old. About 54% identified as an ethno-racial minority, 93%, so the vast majority identified as cis women and also mainly heterosexual, and about 61% were Canadian born. Now, our interview sample for staff, as I mentioned, we purposefully selected these participants from our survey sample. We had 11 frontline and 7 leadership. And we tried to select participants based on ethno-racial identity and as much gender and sexual identity representation as we could, but as you can see from our survey, we were limited, and also striking a balance between both Canadian born and born outside of Canada. We also considered organizations worked at and services and programs, which I'll show you in just a couple slides. Before I do that, a little bit more about our sample of survivor participants. So as I mentioned, we interviewed 10 survivor participants. The average age was 43, and most were between 36 to 50. 70% of our survivor participants identified as an ethno-racial minority. Again, most were cis women and heterosexual, about 50-50 Canadian born versus born outside of Canada, and most were economically marginalized. So 60% were unemployed, 90% had a household income less than $20,000, and 30% of our participants required interpretation. Now, as promised, in terms of participation from across different areas of the VAW sector, we had both staff who worked at generalist and community-specific organizations and survivors who accessed services at both generalist and community-specific organizations. We also saw participation across non-residential and residential services, so about 50-50 for our staff participants, and all of our survivor participants had accessed non-residential services, and 80% had accessed residential services during the pandemic or at some point prior. And in terms of program types, a diverse array of programs were represented in terms of staff specialization and in terms of services that survivor participants had accessed, ranging from mental health and crisis support all the way to legal support, as well as shelter and transitional housing. So for the bulk of the rest of the presentation, I'm going to be going over the answers essentially to our 3 research questions. Just before I do that, I'm just going to double check because I can see there's something in the chat. Just want to make sure I'm not missing anything. Okay, perfect. So there will be some breaks throughout where you can ask your questions, but do feel free to also just type your questions as we go. And at those breaks, I'll take a moment and pause and I can answer those questions. And then we'll also have a bit of time at the end of the session for a Q&A period. So the first question was, how have VAW organizations adapted to the COVID-19 pandemic? So we saw that VAW organizations were able to continue offering many of the same services that they offered prior to the pandemic during the pandemic. And the sort of most common services that continued running during the pandemic were risk assessment and safety planning, telephone crisis support, advocacy, and service referrals. That being said, nearly all of our participating organizations adapted their in-person programming, or at least one of their in-person programs, to be virtual or telephone-based. And so reflecting that change, 3 out of 4 of both frontline and leadership participants reported that increased learning and capacity around technology was the greatest opportunity that came out of the pandemic. Now, that being said, staff highlighted how switching to virtual services had both benefits, but also drawbacks during the pandemic. So benefits, of course, included broadening service access and engagement, so no longer having to worry about things like commute or in some cases geographic area, and also the benefits of using video conferencing and instant messaging to actually mirror those sort of intimate and unstructured aspects that are valued in VAW work. At the same time, however, staff also mourned the loss of in-person services, and this was especially the case for those staff that were only working on phone-based service delivery. This was particularly challenging when staff were working with clients who are staying at home with their abusers, clients at serious risk for mental health problems, those clients requiring interpretation support, those clients who are elderly or less technologically literate, and those who are experiencing economic or housing precarity. Now, both residential and non-residential services made program adaptations. However, residential leaders more often reported dramatic program changes, including needing to use hotels, implementing mandated infection prevention and control protocols, and reducing capacity of their services. On the other hand, non-residential leaders indicated dramatic increases in their VAW caseloads and also the severity of the cases and the need for an expanded VAW workforce to be able to address these changing caseloads. So non-residential frontline staff in particular, compared to residential frontline staff, reported more increases in clients who do not speak English, who are refugees or immigrants, are living with children, clients who use drugs, and clients living with disabilities. And just sort of reflecting the differences in changes that residential versus non-residential staff experienced, I've just got two example quotes that I'm going to share with you. So the first comes from a frontline shelter worker who shared, "We had to move all our clients to a hotel setting. So we had to facilitate this move as smoothly as possible. And then we had to create an office in the hotel, so we were close to the clients. We ran our program from our hotel, which was unfamiliar. There were so many things to adjust to making sure clients have all their needs met." In contrast, a non-residential service leader shared with us, "Our wait list went from 2-3 weeks to now closer to 6 months, like 200 names. Before the pandemic, our agency was the size of 22. Now our agency is the size of 32, and most of those are frontline resources. But we're stuck with a very hefty wait list. But we can't like farm content out and have someone share our load because we're the only one in our community." So really sort of demonstrating those differences between having to make those dramatic shifts in programming changes and maintaining in-person services and implementing infection prevention and control protocols that we saw in residential services versus non-residential services, all of a sudden dealing with a much larger wait list and caseloads, having to increase their staff in some cases to be able to respond to those caseloads. And in particular, in this example, we see some of the additional challenges that were faced by community-specific organizations who didn't really have, in some cases, other organizations to work with or to refer out to because they were the only ones in their community. So now for that second research question, how have contextual factors influenced VAW service adaptations and delivery? So frontline and leadership reported increased workload and keeping work and home life separate as the greatest challenges impacting their personal health and well-being. Frontline also reported personal challenges around the pandemic, while leadership reported difficulties maintaining staff morale. So in light of these sort of additional challenges and burdens that came with the pandemic, our participants reported significant symptoms of anxiety, depression, and vicarious trauma during the pandemic. And 61% of frontline and 81% of leadership participants indicated that their work was more distressing during the pandemic compared to before. And so this quote from a frontline shelter worker really demonstrates what this increased mental health burden was like. So they shared, "Working in isolation is hard. While we continue to provide support to the most vulnerable members of society, we are also experiencing additional personal stressors because of this pandemic. Many workers hope that by the end of this pandemic, their own mental health does not suffer in the process. This is a very scary reality for many frontline workers." And what we can see in both our survey and in our interviews, this sort of uncertainty and stress of the pandemic was also very much reflected in the experiences of leadership staff as well. Now, the most common supports offered to VAW frontline staff were staff meetings and more frequent supervision meetings. And while all supports that staff received were highly rated by them, so they tended to receive ratings from somewhat helpful to very helpful, the highest ranked supports among frontline staff in terms of how helpful they were additional personal days, flexible working hours, reduced workload or responsibilities, and pandemic pay. VAW organizations that had established cultures of teamwork and resourcefulness really facilitated staff resilience and their ability to adapt to pandemic-related challenges. So for instance, one residential leader participant shared, and so I said to the team, guys, reach deep and remember these strategies you guys learned because we are going to need it. We don't know when this thing is going to end, but we're going to need to use every internal and external resource we have. And so as this example really shows, this organization already had sort of lessons learned and training experience to draw upon that they then used to help support their team in navigating the challenges of the pandemic. And so this really shows that integral to the success of a collaborative approach, organizations really needed to have appropriate funding, adequate training opportunities, and staff capacity. And unfortunately, many of our participating organizations indicated that they received insufficient funding for the adaptations that they had to make amidst rising caseloads and case complexity. And this was especially the case among our residential participants. 48% of residential leadership reported that they did not receive adequate additional funding despite the extensive adaptations that they had to make to their programming. So staff across residential and non-residential services expressed how extra funding would help them serve their clients. One participant shared, we also need extra support, like we need extra funds to be able to provide that support. I feel like we're just understaffed. Now, those who did speak positively about funding during the pandemic tended to highlight the benefits of flexible funding. So for instance, one non-residential leadership participant shared, that's probably the biggest help because clients don't have to be eating garbage before we can help them. They could be, too much money for that, but not enough money for this. We can provide clothing. We can provide money for summer activities. We can provide computers. We can provide winter coats. We can provide upgrading. So some very concrete support we can provide. Now, what this quote does exemplify, though, is that organizations had to have enough funding in the first place in order to benefit from flexible conditions. And this tended to more often be the case for multi-service organizations who could move funds around different programs, and especially those with larger pools of charitable and private funds. So really speaking to the inadequacy in some situations of public VAW funding. So 84% of frontline and 94% of leadership, so nearly all of our staff participants, reported that referring out to other services because they were closed, disrupted, or at maximum capacity was a challenge during the pandemic. And this included shelter, housing, legal, counseling, and healthcare. And it was especially exacerbated, again, for community-specific organizations. So there was a recognized need among our staff participants to strengthen the VAW referral process across the sector. So for instance, one participant shared, they called or emailed 3,000 agencies to say, are you open? Because we didn't want to refer women to an agency that's closed. That is something on a bigger scale that we're trying to look and say, how do we fix this? So there definitely was recognition that there needs to be a more systematic process put in place with accountability and transparency around VAW referrals. So before I move on to our final research question, I just want to pause and see if there are any questions. Feel free to pop them in the Q&A. Okay. I will continue, but feel free to pop any questions you might have into the Q&A, and I will answer them at the end. Okay, so our final research question regarding survivor outcomes. So how well have VAW services been meeting the needs of survivors during the pandemic? So staff participants were more likely to agree that their clients were experiencing negative rather than positive outcomes during the pandemic. And this, the sort of most commonly stated outcomes were more severe forms of violence and clients experiencing a loss of power during the pandemic. And this was reflected in the stories that our survivor participants shared with us. So survivor participants noted increases in violence that they experienced during the pandemic compared to before, and ways that the COVID-19 pandemic played a role in their abuse. So for instance, this is actually from a survivor participant, not a residential leadership participant. So a survivor participant shared, actually, he didn't have any job even before the pandemic, but it's more difficult to get a job after a pandemic. So he got stressed a lot. So before he met me, he got a lot of pressure from his own family already. He couldn't do whatever he wanted to do. And after a pandemic, he didn't have anybody else to explode his emotions except me. So really showing how the isolation of the pandemic increased the abuse that some survivors experienced. So as with staff, survivors described both challenges and benefits of virtual services. So for instance, one survivor participant shared, I was using the services before, but because they were being more active in person and social, it helped a lot more, you know? But now it's like you talk to someone on the phone, and then I have to deal with the rest of the situation by myself and learn to cope with that. So this participant really showing some of the challenges of virtual VAW services, feeling like they were getting less out of those services and less engaged, and that they actually had to go out and access more programming than before. On the other hand, another participant shared, actually, I thought the telephone service was the most comfortable way for me, because if I want to show my face, it was really uncomfortable and it was just a shame to me. And then if I get a service through a telephone, I can cover my face so I can open 100% of my story. So on the flip side, we see that some survivors actually prefer the anonymity that telephone services could provide for them. And even with video services or video conferencing, that option to keep your video off, at least in the beginning, was a real comfort for some participants. So sort of speaking to the benefit of being able to offer both virtual and in-person services. And this was really reflected in what our staff participants shared with us sort of later on in 2021. Many staff plan to run hybrid services as part of their post-pandemic VAW work. And this was really meant to meet the widest scope of survivors' diverse needs. So we do expect that this will be the kind of continued approach and the continued model that we see across VAW sectors. Now, in many cases, we heard of a structural context of inadequate funding, resources, and public health support in the face of provincial mandates around infection prevention and control policies, which led in some cases to added stress for staff and further trauma for survivors when accessing services. So for instance, one residential leadership participant shared, we got positives in late 2020. And again, you think you're going to call this line for Toronto Public Health and get the help you need? No, you don't get a call back. You don't get a call back after leaving 4 messages saying, I really need this. One survivor participant shared, one time they isolated for personal reason, like to punish me. They isolated me in the room for 4 days. And they said, you can't come out of this room until we ask you to come out. And so you can see in these 2 quotes sort of the example of staff really struggling to get that support from public health, especially during the study period 2020 to 2021, having to implement these infection prevention and control protocols for the first time without a VAW specific lens, and then how that was reflected back in the experiences of survivors who sometimes felt like these isolation protocols and quarantine protocols were further traumatizing and re-victimizing for them. Now, despite the challenges that were experienced by the VAW sector in general, and especially during COVID-19, we heard stories of staff going above and beyond to support women, and survivors being so positively impacted by VAW workers and services that they actually started volunteering and giving back to those organizations amidst the pandemic. So the sort of power of VAW services as life-saving services during the pandemic is really well reflected in this quote from one of our survivor participants. They do amazing work, and these are the women who this organization has kept me alive. You're surrounded by women from a variety of different life experiences, and it's incredibly rich, and it's not maudlin, and it is full of love and support. And so taken together, our research really illustrates that VAW services are essential, and the detrimental impacts of not funding or prioritizing the sector and really social care systems more broadly. So in the last few minutes of my presentation, we're going to go over the recommendations that we co-developed as a study team, as an advisory, and with the VAW sector and community. And then we're going to talk about the next steps of this work, which includes expanding across provinces. So this is just a highlight of some of our recommendations. We do have more, and I will direct you to where you can look to find more information. And of course, we can talk about that more in the Q&A section. But we recommend increased funding, first and foremost, to VAW organizations. This includes for developing staff capacity and resources for client engagement, to address increasing VAW caseloads and survivor needs, to expand structural supports, which we saw were so helpful, including flexible hours and pandemic pay, and to address staff mental health needs, and to secure equipment access, including both technology, especially with the wide implementation of virtual services, as well as personal protective equipment or PPE. Organizations, including VAW organizations and their service partners, should use increased funding to establish sustainable wraparound supports and to design and implement a hybrid approach to programming, so including both virtual and in-person services. And both of these must account for the diversity of survivors' needs, so especially considering those intersecting experiences of marginalization that VAW survivors might be facing. We also need to see increased investment in strengthening VAW referral pathways and intra, so within the VAW sector, and inter, so with other sectors, collaboration and coordination, including funding permanent coordinators and advocates to be based in other sectors that are commonly working with VAW. So that includes health, that includes justice, that includes housing, and more. Public health units should work in collaboration with VAW organizations, survivors, and other experts to design infection prevention and control protocols for congregate care settings that account for the needs of VAW survivors. So really needs to be trauma-informed and survivor-centered. And finally, there needs to be an increase in the financial and social supports available for newcomer women experiencing violence, including emergency social and housing supports that can be available to newcomer survivors prior to them receiving their permanent residency status, and also interpretation and culturally competent supports. So in terms of next steps, so I do want to direct you to our website, www.vawresearch.com, which has our full report, beautiful infographic summaries that were co-created with the Canadian Housing Evidence Collaborative, or CHEC, and also all the latest news on this study, the Marco VAW study, as well as our expanded project. I do also want to highlight some of the outputs that are going to be coming out from this project over the next few months. So we have an upcoming output around recommendations, for Canada's National Action Plan to prevent gender-based violence. This is actually going to be one of the first qualitative analysis of survivor, leadership, and frontline recommendations on what should be included in this plan, which is so important, of course, because we still have yet to see a finalized plan. Recommendations and best practices for virtual service delivery, pandemic preparedness, monitoring and evaluation practices, mental health needs among both VAW staff and survivors, hidden homelessness and securing housing for VAW survivors, which of course we were able to speak to a little bit more at yesterday's panel with CMHC, and study methods. So how can we actually strengthen community-based research in public health emergencies? What have we learned from this study? So I'm very happy to share that we've received over $600,000 from both the Canadian Institutes of Health Research and Nova Scotia Health to expand the study across Ontario, Nova Scotia, and New Brunswick. And so, of course, in part, that's going to help us address this question that remains of how generalizable are these results from the GTA to other areas of the country. So we want to investigate the state of violence against women's services across these 3 provinces and to look at how well are these services meeting the needs of survivors. And with that, we want to identify best practices for strengthening systems responses to VAW that are really sort of accounting for the different needs of different areas within provinces, between provinces, and also within different communities of survivors. And I also want to highlight that we're hiring for this work. So we are looking for both full-time and part-time positions. You can visit our website to find out more, or feel free to email me. And a final plug for our website. On that website, there's a contact form where you can actually provide feedback directly to us around your questions, your thoughts on our results or on our next steps. So of course, we're now going to have a Q&A session, but if you find yourself percolating around different things and you want to think about it and get back to us, absolutely feel free to use that contact form or to email directly. So just to close, I want to gratefully acknowledge all of our participants who made this work possible: our advisory group, the Toronto Region VAWCC, the Women Abuse Council of Toronto, who helped support our peer researchers, and of course, the funders of the study, without which we wouldn't have been able to do this. So thank you for listening, and I would love to hear any questions you might have.